Good afternoon, and thank you for joining us today in this Image Challenge live stream event from Retinal Physician. My name is Marianeli Rodriguez. I'm a retina specialist in Worcester, Massachusetts with Vigil Retinal Associates. I have no financial disclosures. As you know, our plan is to post an image challenge each month and then discuss the diagnosis and management using this platform. We'd love to hear your thoughts online, and you can find us on Facebook, Instagram, LinkedIn, YouTube, and Twitter. And you're also welcome to write in the chat and share your thoughts as we go through this event. Today, I'm joined by Dr. Irene Roh from Atrius here in Massachusetts. Irene and I know each other from Mass A&E, where we were co-fellows, and I love catching up with her, although we say we have to do it in person. Welcome, Irene.
Hi, nice to meet you all online. And you too, Mari.
Yes. So I want this to be a super dynamic discussion. I want to pick your brain on a very common, topic that we treat all the time in our retina clinics. And, I'm just going to jump right in. So this 64-year-old lady presented with a blind spot in her right eye. She had normal intraocular pressures and unremarkable anterior segment. She had 2+ NS. And her vision, when I met her, she was 2100. I also have a fundus photograph of the posterior exam, which you can see here. So if you could just describe what you're seeing, for those of us that are familiar with it, or even residents, fellows, medical students that are also clicking and joining us today.
Sure. So this is a fundus photo of the right eye. The optic nerve looks very pink, healthy. The vessels look very healthy. The peripheral retina looks good. We probably have to dive right through to the macula area, which we can't really see clearly, but I can see that there's some kind of abnormal reflex in the fovea area. And usually...
We can go back to the OCT maybe, and you can see that.
And yeah, definitely nowadays we have OCT, but if we just look at the patients, we can actually look through the slit lamp and do like a Wansky-Allen sign to see if there's any distortion on the slit beam. And then obviously nowadays we have the OCT. You can see the OCT of the macula area. It's basically you do have a full thick macular hole. The smallest size of the hole is very small. So I would think that it would be less than 250 micron, and the
So Irene, I think I lost your
area of the retina with some cysts. Usually. Oh, can you hear me?
I can hear you now. Yes, sorry, just went in and out for a second.
Okay, so to say that again, on the OCT, you can see a full thickness macular hole. When you're looking at the inner size of the hole and the outer size of the hole, you can see that the smallest area of the inner hole is probably, I don't have the calibrator, but like 250 microns. So it is a small hole in a sense, but also has cysts around the inner retina. And then if you look at the vitreous area, the hyaloid is still on. So you can say that it does not have a PVD. So that would be a stage 2 to 3 macular hole.
Yes, so that's really great that you mentioned that, because we love to kind of like categorize things as retina specialists, and you kind of hinted that this is a stage 2 to 3 hole. I called it a stage 2. Can you just go over the stages of a macular hole and the way that you think about it, and why that matters?
Yes, I think there's very many different type of staging. The most common one, which one is the stage 1, 2, 3, 4. Stage 1 is where you just have the fovea kind of tenting, not a full thickness hole. Stage 2 is when the macular hole is very small, less than 250 microns. Stage 3 is if the smallest area of the hole is bigger than 400 micron, you're stage 3. And that one in a stage 3, you do not have a PVD. In the stage 4, it's the whole size is 400 micron, bigger than 400 micron, and you have a full PVD. So that's the most common one.
Yeah, so and that's the same kind of staging that I use. And I think it's important because when you're doing surgery, that might really change your management of the way that you're approaching. And we will discuss and dive into that a little bit later. But, when we showed this to our viewers, we wanted to know from them what would be their approach to this problem. And you could see here in our polling that the majority said that they would treat this with parspinal vitrectomy with ILM peel and gas. Some people said that they would just treat it. 10% said that they would do parspinal vitrectomy just with gas and not do an ILM peel. And even less people said that they would do a PPV with an ILM peel and not do gas. So just kind of like, I want to hear what you would do in a case like this. And I know that, you ask 10 retina specialists and they will all give you a different answer when it comes to macular holes. So what would you do?
So what I would do is, even in this case, I would do a PPV, island peel, and gas. That said, in this case, if it's a stage 2 and the hyaloid is on, we know that the main problem is the hyaloid. And in theory, if you have a perfect hyaloid off and put gas in, you can kind of skip the ILM peel. We always kind of add the ILM peel to make sure that the full hyaloid is off. So that would be my preference in order to have the highest success for the patient.
I would do the same thing, and that's what I did for this patient. But when I came out of fellowship, you and I trained in the same place, and some of our attendings never peel ILM. And when I started, as a fresh out of fellowship, I said, okay, well, I'm going to take this knowledge and I'm going to not peel ILM when I see a stage 2 hole like this, especially when you see that the hyaloid is there.
Mm-hmm.
So I did that with one patient, and the hole didn't close. And I was like, that's it. I'm peeling ILM for everybody. So and I have a higher success rate with ILM peel, so I'm just sticking to it, and I'm not even really thinking about it in that way anymore. So it just took one
Exactly.
to jade me. So
Exactly. I like, the theory, but then again, when you think about the patient, you kind of think of the highest success rate with the, most minimal procedure that you can do. But I think ILM peel really kind of highlights that you do have the hyaloid off and the traction off. So that would be the way to go for me too.
yeah, and it's pretty easy. It takes only like a few minutes. So I tell the patients, tell them the pros and cons. Yes, there, you're right there in the macula. You can cause, hemorrhages, you can cause damage, iatrogenic damage to the retina. But I think, most retina specialists wouldn't have those complications. And that patient, the one that I did not peel ILM that first time, and I had to do surgery again, he closed really nicely with the second surgery. So
Nice.
he ended up with good vision. So at the end it worked, but I just don't want to go through that again. so
Exactly. Exactly.
so there's some people that talk about the medical management for macular holes, in treating the patient with prednisolone, ketorolac, and dorzolamide. Do you ever do that, or do you ever try it even in like stage 1 holes, or
So I did try it, but like I think that in patients that is gonna close, really really small ones, even if I don't give the medication, I think they'll close. So
yeah,
they are spontaneous closure. I think the medication helped. Um, Not
maybe?
really, maybe.
Yeah.
And like, but if it goes beyond stage 2, I tried once because the patient requested it, but I knew that wouldn't be working. So, but I think there are some cases, especially if they started off with vitreomacular traction syndrome, and when the hole is very small and the vitreomacular traction is completely resolved, you can wait a week or two, and they will close.
Yeah. Yeah, I've never tried it. So it's one of those things that I'm like, "Oh, this is really interesting," but, surgery works, so I
Yeah.
don't really do it. So what about your choice of gas, of tamponade in general? Like, do you ever use oil? What kind of gas do you usually go to? Does it change depending on the stage of the hole?
So usually, if it is stage 2 or less, I would go to SF6. If it's stage 3 or more, C3F8, 14% is my choice of gas. If possible, I would not put oil in. And if it is that somebody has to fly, I would rather have them go to their home and then get gas rather than oil. So, and it's okay to delay 1 to 2 weeks. Most of these people already had symptoms for over 6 months, so I don't think there is any you know a need for a oil in especially macular hole cases.
Yeah, I do the same thing. There is one patient, obviously like we are excluding the patients that have RDs from macular holes. Sometimes in those, you could argue for oil for those patients. Um,
Hmm.
that other excluding those just from a simple hole, I agree. I usually always use gas.
Right.
And um yeah, in terms of my choice of gas, I'm kind of like with you. I tend to go more C3F8 than SF6, unless, for this case, I did SF6, but a lot of times I do C3F8. And I think it's because I trained with Elliot and he always does C3F8. So I'm like, if it works for him, I'm just going to do it. So,
I had a patient who had really severe vitreomacular traction, was watching it for like years. Her vision was 20/40. It had really, and then at the end, she did develop a macular hole. But because it was a vitreomacular traction, it was such a small hole. I decided to put SF6 in that eye. Actually, the hole closed, but then again, there was uh, a subretinal fluid under the fovea for like over a year.
yeah.
And but like after the year, like the vision turned to 20/20, which is great. But then again, her left eye had the same thing. So
Yeah.
this time I put C3F8 so that we can kind of like, maybe I'm hoping that it would not take a year for her vision to get better. So
Yeah, I've had those cases where you see that little blip of SRF and you're just like, please go away. But
yeah.
it usually does clear, but it takes a lot of patience. Uh,
Yeah, I like learned like it's like literally took a whole year for but it did go away. So
yeah, exactly. So,
mhm.
so it seems like you and I are pretty much in tune, kind of like with what we do. Do you ever try any of those ILM hinges or flaps that people describe, like the taco or reverse
um,
taco or
I
anything like that?
I have tried the ILM hinge and then the ILM flap. Um, Thankfully, I only tried it once or twice for the ones that were really big. They did close, but then again, like also tried on like not doing it and it closed too. So, and making that hinge would take longer time. So,
Yeah.
I only would use it sometimes when the fellows, the trainees want to do it together with me. So,
Yeah. So I
mhm.
I only I operate by myself. I don't have fellows or any other assistant other than the technician. I've only tried that once, and I tried it in a patient that was very, very myopic. Actually, peeling that ILM was really hard because she was like the eye was so long,
That's a
and
lot.
yeah, and she actually ended up closing. The vision didn't improve at all. So I was like, and we went through this heart surgery. Her vision was the same. She was like, I still don't see any difference, but the hole was closed. Sometimes these holes can be very and that's one of the things that we have to talk to our patients. Your vision might not get better at all even if the hole closes. And so that's like one of the things that I always spend a lot of times pre-op with the patient. And I tell them, sometimes your vision is not going to get better, but this is to prevent the hole from getting bigger so that you don't lose any more of that central vision. So having that discussion early, I think is important. So
I definitely agree too. And then when you look at the pre-op OCT, if you look at the photoreceptor area, and if it has like that shadow right underneath the fovea, you can kind of presume that it has been there longer. And also that is a risk for not improving vision after the surgery. So I do look at the photoreceptor area before the surgery, and after the surgery, as you look along, you can actually see that photoreceptor coming in, and those would be the one that would eventually get vision better. But if they have the outer retina degeneration with the photoreceptor degenerations, those unfortunately are the ones that the vision is limited.
Yeah. And, do you ever try, some people argue for autologous platelet-rich plasma. I've never tried it for the really big holes. Have you ever tried it?
No, I have not tried any of those.
Yeah.
So
And what about the retinal transplant?
it,
And do you believe in, I mean, it does close the hole, but, some people,
right. I
yeah,
actually, I think it's too much of a surgery, which can increase the risk of PVR retinal detachments without improvement of vision. And we always have to think this macular holes are patients, usually female, they're over 65 years old. And, I would have to think about like the life, what the quality of the life would be afterward and what the vision improvement would be. To the, patients, I I still have a hard time kind of convincing myself that that is really the best thing for the patients. I think it can close hole, but I don't think it has shown to improve vision to a degree to go underneath, go through that surgery for me. So I think for me, if I would have to think, would I be getting that surgery if it was my eye? And my answer would be no for me. So then I won't really do it for my patients either.
yeah, I'm kind of with you. I don't want to have the risk of retinal detachment while doing a surgery that I don't think
Will improve.
improve things too much. Yeah, I'm
Mhm.
kind of like in the same boat as you. Um, and then I can show you kind of like the results for this particular patient. She was actually happy. She closed, and her vision improved. And I think because the hole was small, once we brought that together, she noticed a big change. So she was very happy. One thing I want to talk to you. What do you do? Let's say you did it all. You did ILM peel, you did 14% C3F8, and the hole doesn't close. What's your go-to? What do you do at that point?
Uh, you like definitely like if you go into a second surgery, um, I think at this point, like you can try the autologous transplant. That would be the thing if there is like really a you did the island peel, big island peel. One other thing is that, sometimes you just have just the macula, the fovea area, the island is off, and you do have some island left. You can make a bigger island peel and then probably cover that at the area. Thankfully, like
Doesn't happen too often.
it doesn't happen too often. Exactly.
Yeah, I can think out of less than 2 or 3 cases for me in this last 4 years in practice. One of them, she closed after I actually used 16% C3F8 with that second surgery, and I just peeled to the arcades
Mhm.
ILM, and she closed. And then I have not one patient actually, and then I told you about the one patient I didn't peel ILM, that closed with the second surgery after I peeled. And then I have one patient that actually, after 3 surgeries, he hasn't closed. And, I've done it all with him, and I still kind of like scratch my head thinking, like, would he have closed with an initial? Because he was pretty big at the beginning. Maybe I should have done a hinge at the beginning. I kind of like go back and forth. Should I have done an autologous from the very get go? But then I have had other patients with the same size hole that have closed very nicely. So he wasn't the best at face down. That's the only thing. But because he had some neck pain, maybe that's. But I kind of like drilled it back to him, like you have to face down, you have to face down. And I think the third one he did, but it just didn't work. So
Yeah, by the third surgery, I think you do have to discuss it. But on the point of face down, yes, face down is such a pain in the neck for the patient.
right,
However, I think there is some meaning to it. I always tell the patients, like in an hour, to do 45 minutes down and 15 minutes up so that you don't break your neck. But I do want to do everything on the first go
yeah,
rather than have to do it second or third go.
right, yeah,
And, trying to convince the patients that this is not to hurt you, but like when we're doing it, we want to do everything that
right.
possibly can increase the probability of the success of the surgery. And talking about that, I think definitely, and getting understanding from the patients of why we're doing this definitely increases our chances of closing on the first go.
How long do you have them face down?
So I would say the first night is very important. But then again, when they go home, like during an hour, you can face down for 45 minutes and then 15 minutes up. You can like go for a walk, you can, eat, whatever, you go to the bathroom. But when you're like not doing anything, do the face down. And also the first night I do face down I do ask them for a week, but during the week, if they do have a lot of issues, I do have them sleep on the side and just do the face down during the daytime.
I usually just do 3 days, and it does work, but
I think
it all from like days to a week to so 24 hours. I don't think that there is like a lot of evidence out there that for sure we know that this is like the magic number.
Exactly. I don't, even if I say 7 days, I think there are very compliant patients who really do it 7 days. But, I try to kind of tell them that we want to do as much as possible that it doesn't, but we really do want it at least half of the time. We do want it down.
Yeah.
And also it's especially for the phakic patients, we don't want them lying back and then having the cataract and progress more. So that's the other side of it.
For sure.
Mm-hmm.
Irene, this was a great discussion. Thank you so much. And
thank you for having me.
I think that's going to wrap it for today. Thank you for tuning in, everybody. You can leave us a comment online or via our multiple platforms. And we hope to see you again soon in another month as we discuss another interesting case. Thank you.